Dr. Aisha, you may continue.
Assalamu alaikum everyone. I hope I find you all in the best of health. I'm Aisha Zulfikar and I warmly welcome all of you on behalf of Giving Back to Pharmacy in Pakistan, which is a non-profit organization and a group of volunteers that focus on transfer of knowledge of best practices in the field of pharmacy to the pharmacist in Pakistan. And these BCPS preparatory classes are an example that how Giving Back to Pharmacy in Pakistan is devotedly working for pharmacists in Pakistan. So today our topic is chronic care in cardiology, which will be presented by our respected faculty member, Dr. Muhammad Bilal. And if you find any queries, you can ask in the end of the class. And Dr. Muhammad Bilal is here with us. He is currently working as an in-charge oncology pharmacist at Sheikh Khalifa Medical City in Abu Dhabi. Sir, thank you so much for giving us your precious time. It's over to you.
Assalamu alaikum. Welcome. It's always a pleasure that if we can contribute something in our profession anywhere, like particularly in Pakistan. So we will start because it's a huge topic without any delay. So chronic care in cardiology. Basically, there are two chapters in ACCP book about cardiology. One is chronic care and the other one is acute care. So I have both of them. So let's begin. So I have not received any financial or commercial funding or support for today's session. No commercial trade names are used in today's presentation, and I do not promote any specific brand. No specific conflict of interest. I have no financial relationship to disclose. I will not discuss any off-label use. And so if we want to understand first our topic is of heart failure, not only of heart failure with any given disease of heart, we should know the basic function of the heart, where the problem can occur, where the things can go wrong. So that's why I realized it important to discuss all those factors, all those functions which a normal heart is performing, so that if there are some changes in the normal functions and normal parameters, so we'll address those changes and we can find the specific function which is not proper or which is not normal. So our therapy will be according to the problem. That's why there are different functions which heart is performing, and I have discussed them shortly. Blood pressure, the BP is the first of them, is cardiac output multiplied by systemic vascular resistance, which is routinely used. And cardiac output is stroke volume plus heart rate, means what's the output of the heart is the volume which is basically coming out of the heart on every beat. And if you multiply with the beats, number of beat, heart rate, you will get what the cardiac output is. And cardiac output, which is the normal, is 5 to 8 liters per minute. Cardiac index, it's just normal thing like cardiac output, just they have calculated according to the body surface area. They just divided by a normal body surface area like 2.2 or 2.1, which is a normal body surface area. And that one is the cardiac index.
Dr. Bilal? Sir, sorry
yes.
to interrupt, your slides are not moving.
But I am on the first slide right now. I am just discussing the points from the first slide. Can you see my first slide?
Sir.
Cardiac function.
Yes, sir. All right.
Okay. So the third point is stroke volume index. Then total ejection fraction. We will discuss this in ejection fraction in detail in the next slides. Systemic vascular resistance, how much is the systemic when the heart is pumping the blood out of it.
Dr. Bilal?
Yes. Yes.
Sorry to interrupt you, sir. Sir, your slides are not moving actually. We are still stuck on the first slide. Can you please?
I will should I share my screen again? What do you think?
Yes, sir. Can you please do it again?
I will just first stop the then I will share the screen again. Okay.
Thank you, sir.
Yeah. Is it
Fine, sir.
working?
Can you change, sir? So we will confirm. Can you
Yeah.
change and come back? Yeah,
Yeah.
great. It's moving.
Okay.
Yeah.
Okay then. So different parameters we were discussing about this cardiac functions. Systemic vascular resistance, this is the resistance which is offered by the vessels of the body to the heart when the heart pumps the blood into the vessels. Preload is called end diastolic volume. End diastolic volume, sorry. End diastolic volume is basically when the heart is dilated at its maximum, and what's the maximum volume it can accommodate is basically the preload. Afterload is the force of or load against which the heart has to contact to eject the blood. Means that basically this afterload is basically a force which a heart to face when he will push the blood into the vessels. So heart failure is a complex clinical syndrome caused by any structural or functional cardiac disorder that impairs the ability of ventricle to fill with or eject blood. So it can be structural or functional. For any reason, heart is not performing its proper function, it will come in the heart failure. Types of heart failure with reduced ejection fraction, and second type is the heart failure with preserved ejection fraction. In first type, with reduced ejection fraction, it's very simple that heart is not able to pump out enough blood which fulfill the need of the whole body, because heart is the organ which has to irrigate all of our body. So the volume inside the heart is going good, means, but the coming out from the heart is not enough to supply whole body. First type is heart failure with a reduced ejection fraction, and preserved ejection fraction is different from this one. Basically, it is defined as a left ventricular ejection fraction of 50% or greater. Borderline heart failure preserved ejection fraction is left ventricular ejection fraction is 41 to 49%. It means that the volume coming out of the blood, the percentage cardiac index is okay, but actually the volume going inside the heart is not enough. And if the input is not enough of the heart, how the output can be enough? Means if something will go in, it will come out. So in the start, it's a heart is not able to accommodate enough volume of the which is normal. So this one is called preserved ejection fraction. How we will calculate ejection fraction percentage? This stroke volume divided by end diastolic volume multiplied by 100. It is very simple that stroke volume is the volume coming out of the heart divided by the volume which was present, end diastolic volume means which is the preload which was present and of maximum diastole. And if the heart has enough strength, if enough power, it will eject like a maximum of its volume out of the body. So which is the normal heart is performing like 70 ml of the stroke volume, means 70 ml of the volume which is coming out of the heart with every beat, and it's divided by the 110 which is the preload which is at the maximum volume inside the blood, and it will pump out about 64%. This is the normal heart function, that it should pump 64%. If you calculate stroke volume cardiac output with 70 ml multiplied by 70 it is almost 4.9 liter per minute. If something goes below this one, it means that our heart is not pumping enough to irrigate or to supply whole body the blood, which will have the consequences which we'll discuss. When it will come heart failure with preserved ejection fraction, actually, if you will see that total volume which is going inside is 70 ml rather than it's 110 ml. Sorry, first we will go for heart failure with the reduced ejection fraction. In this way, in this condition, basically, the volume going inside the heart is correct, 110 ml, but volume coming out of the heart is not correct, means not a normal. It's 44 ml only. So ejection fraction is only 40%. But with the heart failure, the preserved ejection fraction, if you will see that 70 ml total volume was present at the end of the diastolic volume, means total, it was already less 40% than the normal. And when it's pumping out of 44 ml, so still ejection fraction is good, but actually the volume coming out of the blood, coming out of the heart is not enough to supply the body. If you will calculate cardiac output, it will be 3 liters per minute. So these are two types of heart failure. You will see the figures, how they will look like, why it's mechanical like form. In heart failure with reduced ejection fraction is like this, that heart is like a floppy heart. It's like a weak heart. It's not able to contract properly, so that the volume will come out of. And on the other side, preserved ejection fraction, actually it has thick walls which are not able to expand enough to accumulate maximum capacity to fill the heart to its maximum capacity. So basically these two reasons why there are two types of heart failure are happening. When there is a heart failure of, there are two systems activated. First, sorry, it's actually, if we will know these two compensatory mechanisms, we have to treat these two actually compensatory mechanism when we are treating any heart failure. So first of all, if the heart is not functioning properly due to any reason, like which is called primary myocardial injury, means which, for which there are some actions of the heart, some functions of the heart are not good. So to compensate this, there are two, and obviously its cardiac output will drop. Cardiac index depends on whether it's preserved ejection fraction or reduced ejection fraction. We will see in this one, but also basically cardiac output drops. It is sensed by the kidney, it is sensed by the CNS. They will activate their respective mechanism to compensate this one. When they activate this compensatory mechanism, they actually make the things worse, because they will give more, because their function is like, they were thinking that actually the in the body, the volume of the blood is less. They will not consider it as that the heart is not functioning properly. When they will not get enough blood, they will think that there is no enough blood in the body. Actually, they will try to they try to reduce the urination. They will try to preserve. They will try to increase the volume by ways of constriction, so that body can fill and they can get enough supply. So in fact, the heart is getting damaged more in a way that already heart is not functioning properly. It's already weak, and these two compensatory mechanisms make the things worse. The central nervous system operate through like norepinephrine. They let the heart work more. They will let the heart work more like in rhythm, like in power. So if there is some damage, some functional damage or some mechanical damage, it will increase. So we have to basically protect the heart from these two mechanisms when the person is in the heart failure. So the first case is very like proper. It will explain itself that about these two mechanisms. RS, a 58-year-old woman with a history of hypertension, coronary heart disease, myocardial infarction 4 months ago, and dyslipidemia presents to the clinic for a follow-up. She has no worsening signs or symptoms of dyspnea, edema compared with her baseline. Dyspnea, edema are basically symptoms of heart failure, because if the heart is not pumping enough blood, the blood will go in the lungs, it will accumulate over there, and you will feel dyspnea and edema over other way. Edema, the heart will accumulate in the peripheries if it is not circulating very well. Dyspnea will be caused by left ventricular failure, and edema will be caused by the right ventricular failure. And echocardiogram reveals a left ventricle ejection fraction of 35% only. She is in New York Heart Association class 3. We will discuss these classes, means that this is like severe type of heart failure. Her medication include aspirin 81 milligram, metoprolol succinate 150 milligram per day, atorvastatin 40 milligram every night. Her vital signs include blood pressure 138/80, is very well controlled, almost for a hypertensive patient. Heart rate is 858 beats per minute. Her lung are clear. Laboratory results are within normal limits given her history and physical examination. What is the most appropriate modification or current therapy? As we have studied, we are treating one mechanism, like by giving metoprolol 150 milligram, we are just treating central nervous system process that by which he is affecting the heart function. But there is no any other medication which will treat the RAS system, which is produced by the kidney, and the kidney can get damaged. And that's why you will see that its systolic heart pressure is also a little bit more due to renin system is activated. So these are some options. We will continue current therapy, although everything seems very good, but left ventricular ejection fraction is less. Apart from this one, or some systolic blood pressure is some more. Everything seems very good. Some we can think that to continue this therapy. Initiate digoxin. They also always give something to confuse you in the exam. You will see that left ventricular ejection fraction is 35%. No doubt, this is very good answer. But first, to treat this, like this 35% of ejection fraction, you have to add this digoxin, but it's not the first option to go for this one. That's why you have to be very careful when choosing the answer. They have given specific guidelines. First, what is the first step, what is the second step, and what is the third step. Sometimes they will go to the second step. This is also like a recommendation of, but this is not the first choice and first step. First, you have to go always to first step. And there is also like initiate spironolactone 25 milligram per day and initiate lisinopril 5 milligram per day. As I discussed that there are two compensatory mechanisms which we have to treat. First is being treated by metoprolol, and second is not being treated with any like to stop this RAS system. That's why our the next step is always lisinopril 5 milligram per day, because first we have to stop these two mechanisms, then we have to proceed forward. Then you can go to any other thing. So when choosing the answer, all answers you will see that they are correct. But which is the first choice means which is the first step, you have to give the answer. So in this condition, you have to initiate lisinopril 5 milligram per day. So this is classification which was mentioned on this day. So there are two types of heart failure classification. One is American College of Cardiology and American Heart Association. This one is not like discussed in detail and not used routinely in practice. Mostly we use with NIHA functional classes of heart failure. This one is New York Heart Association. In first stage, patient is asymptomatic. He can no limitation in physical activity caused by the heart failure symptoms. Although there are some risks that the patient has some damaged heart or like this, but there is no any symptom. Whatever heart is performing, he is enough to perform his like routine activities, and whatever he is doing, it's fine with this. But in future, that slow process can go to like class 1, class 2, and like this. Like there is no limitation in physical activity, and class 2, slight limitation of physical activities, asymptomatic at first. If the patient is at rest, he is fine, because when he will perform some work, obviously heart has to work more. Your body requirement for oxygen, for food, it will increase, and the blood has to supply, and blood is pushed by the heart. So, but symptoms of heart failure with normal level of activity, it comes with the class 2 pain. Then on class 3, marked limitation in physical activity because of the heart failure symptom, asymptomatic at rest, means such kind of person, like if they like class 2 can perform their daily activities, like when they are doing taking care of themselves, like working at home, like gardening, like this, so and making their breakfast, going to washroom, they will not feel with any activity. But class 3 can also will feel the symptoms in the home, like on the daily activities. There is marked limitation. It is like if they will go to the washroom, or they will like stand for a long time, or they will perform some activities even at home, there will be symptoms, but there will be asymptomatic at rest. Then the class 4, symptom of heart failure at rest, unable to carry out normal physical activity, means that even at the rest, he is not feeling okay. Heart is not able to pump enough blood to breathe normally, to supply the blood to whole body, which is minimum requirement of the body at rest. So class 4, symptoms of heart failure at rest, even means same. Actually, they're explaining this also classes. We don't have enough time to explain to these classes also. I will go ahead. What are the goals of the therapy? Basically, first of all, you will realize what is the problem. Then you will go, where is the problem? Because there are many functions of the heart performing. You have to closely observe that where the things are going wrong. You have to fix those, and you have to fix according to the protocol, according to the guidelines, how you will fix them. So goals of the therapy: modify or control risk factors. If there is hypertension, obesity, diabetes mellitus, manage structural heart disease, reduce morbidity and mortality, prevent or minimize sodium or water retention, eliminate or minimize heart failure symptoms, block compensatory neurohormonal activation, cause reduced cardiac output, slow progression of worsening of cardiac function. These are some goals which we have to consider when we are giving someone heart failure therapy. How we will give the heart failure therapy? In stage A, which is NEHA class 1. So in this, ACE inhibitors are in all patients, beta blockers in selected patient. First, if you will go that question, the patient was receiving beta blockers, but it was not receiving ACE. So actually, ACE should be started first. So sometimes they are also like confusing from this one. The patient is already on beta blocker and metoprolol. The next step is to start the digoxin, but they have already missed the first step of starting the lisinopril ACE inhibitor. So that's why you can also confuse that the patient is already on beta blocker. He's already on second step, he should go on the third step. But you might ignore that the first step is missing, that first step, they should start ACE inhibitors, which are missing from this case. So secondly, if it comes class 2, like if the patient is feeling symptoms when he's working at home, so at rest he's fine, then he should go to like beta blockers and ACE inhibitors, these two. When we have done with these two compensatory mechanisms, then you can go forward to diuretic and your digoxin, depending on the condition. Like if the heart is very weak, then you go for digoxin. If you feel that there is edema, there is some pulmonary volume in the lungs, there is volume accumulation, there is some fluid, so you can go for like diuretics. So in the class 3, then there is different therapies like revascularization, mitral valve surgery, or depending upon the problem where it is, consider multidisciplinary team. Then inotropes, stage D, most of the time stage D needs the heart transplant. Means first, sometimes they put some pacemakers. So these devices, if the problem is there, if the problem is in electrical current. So there are advanced management. We are not, I think, not very discuss in detail, and there is no any much detail in even the book. So this is the second case. JM is 65-year-old woman with a history of hypertension and poor medication adherence, who present to her primary care physician with shortness of breath, markedly decreased exercise tolerance, and echocardiogram reveals and left ventricular ejection fraction 65%. With diastolic dysfunction, GM medication includes her vital signs include, GM medication include an extended release nifedipine 90 milligram per day, hydrochlorothiazides 25 milligram per day. Her vital signs include 128 over 70 millimeter mercury, heart rate 98 beats minutes. Her lung fields are clear to escalation, and there is no evidence of systemic congestion, which is the best pharmacological management of GM. You will feel that here left ventricular ejection fraction is 65%, but there is still there are still symptoms. So it means that this patient is facing preserved ejection fraction, not the reduced ejection fraction. You have to diagnose the things from the case where the problem is. And the second thing, you will see that the heart rate is 98 beats per minute. It's like, again, a risk factor if the heart is already in problem. So 98 beats per minute is another wrong point where you have to consider the therapy. Discontinue, what are the options? Discontinue nifedipine and initiate diltiazem for 50 milligram per day. Discontinue hydrochlorothiazide and initiate furosemide 40 milligram per day. This will not make any difference, much difference, although there is furosemide is more important, but hydrochlorothiazide, if lungs are clear to escalation, there is no evidence of systemic congestion. It means that hydrochlorothiazide is working good, so no need to go for this one. Next thing, initiate digoxin 0.25 milligram per day. If the heart is beating already at very high rate, and if you start digoxin, it will increase the work life. Add lisinopril 5 milligram per day. The patient decrease exercise tolerance. For this patient, if you will see that it's left ventricular ejection fraction is still good. So you will also not consider this one as lisinopril, because this one lisinopril is given in reduced ejection fraction, not the preserved ejection fraction particularly. So first option which will come, either you can go when first you will start with this, treat this high rate of heartbeat, like you will discontinue the extended release of nifedipine and initiate diltiazem, because nifedipine acts on peripheries and diltiazem will specifically act on heart, so, and also peripheries, calcium channel blocker. So it will reduce the heartbeat and reduce this heart rate. If this will reduce the heart rate, the heart will be able to perform more well. Hopefully it will resolve the symptoms. This is the best option in this case. Symptom, atrial fibrillation. The next topic is our atrial fibrillation. Some patients have no symptoms in atrial fibrillation because despite of those fibrillation, the cardiac output is okay. So they will not feel any symptoms. They will feel only symptoms when there will be disturbance in the cardiac output. Potential symptoms that may be present to some degree include the following: palpitation, chest pain, dyspnea, fatigue, and lightheadedness. Rare cases of thromboembolic events. These are just directly related to cardiac output if the cardiac is not performing well. So these are the, and thromboembolic events occur because of the flow. If the blood is not in the flow, if it like pool anywhere in the heart or in the vessel, it gets coagulation, it's get coagulated. So you have to keep the blood running. If it like pulls somewhere in the heart when the artery is not contracting properly, there are some spaces behind the wall where the blood gets stagnant. So their coagulation start. So these events happen, like they can cause stroke, they can cause PE, pulmonary embolism. This is basically pathophysiology, like where how the atrial fibrillation is affecting that. I'm always interested to show the pathophysiology, because if you understand very well the problem, you can treat it well. So if you're not understanding the problem at first point, then there will be difficulty in treating it. So as our normal heart function, sinus node produces the impulse, which is basically electric current, and it moves first to the atria, and atria contract. After this, it passes to the SA node. SA node delays a little bit this current, so that the first atria should contract, then the AV node should, then the ventricle contract due to this delay. First, when atria will contract, it will pump the blood in the ventricle. At this time, the ventricle will be relaxed. After the contraction, after the finishing of the contraction of the atria, the ventricle will start contract due to the delay of the AV node. But in atrial fibrillation, there are different reasons. There is basically disturbance in the current of heart. So some heart, basically current is the one who is making the heart to perform like of the contractions. If it is, there is the current is not proper, this electrical activity is not proper, it's not normal, the heart will not perform normally. There might be different reasons. Some reasons it has discussed that there might be many pacemakers. If there are many pacemakers, the electric current will be distributed and the artery will not properly contract at one point, at one time, so that it will not pump all of the blood to the ventricles. And same abnormal electric current will go to the ventricles, and ventricles will also receive abnormal supply of the blood, and they will also not contract at one point, means at one time coherently. Like if you will see the ECG, normal ECG, there is some time gap when P wave, when artery is contracting, and QRS wave, when the ventricles are contracting, there is some gap. After this, they will relax and they will accumulate enough blood. They will get filled with the blood. Then they will contract again and they will pump out of the blood. But in the atrial fibrillation, there is nothing is normal. Like any wave can pass through the ventricles, and ventricle contract on, and like unusual rhythm, sometimes very quickly, sometimes very lately. So basically, the problem is with the electrical activity, and which is like making the things wrong on the functions of the heart. So we have management. How we will manage this problem in the electric current. There are different pharmacological therapy basing on basically how the heart is behaving abnormally. So we have to, that's why I'm discussing this detail where the things are going wrong. If the ventricle rate is high, they will start ventricle rate control. Rhythm control, the second option, pharmacological cardioversion. When pharmacological cardioversion, they will give medicine to decrease this current activity, like blocking sodium channel, blocking calcium channel, delaying the opening of sodium channel, because these are the ions which are dealing with electrical conduction. Then antithrombic therapy, as I told, that when the blood is pooling somewhere, it gets coagulated. So you have to give antithrombic therapy also to prevent any like stroke or pulmonary embolism. The non-pharmacological therapy or cardioversion. Cardioversion is basically when heart rhythm gets disturbed, sometimes they just put electrical current in the rhythm so that heart will get back to that rhythm. Basically, AED, automated external defibrillator, they also train the people when you go for basic life support programs. And when someone gets fainted, so how you will deal the situation. It's like, I think all in here, I think all health professionals need this BLS training. I don't know about Pakistan. So these AED devices are available on different spots. If like some people get syncope or some fainted, so you have to, how you have to use this device. There is some training, like one day you can finish this training. So basically this is also a atrial fibrillation condition. AV node ablation, sometimes the electric current from the AV node is passing more than the needed, like or quickly than the needed, then they do AV nodal ablation therapy. Means they will destroy some tissues of AV node so that the exact delay and duration should be maintained. Then there is pulmonary vein ablation, different ventricle rate control, goal heart rate less than 80 beats per minute.
Wow.
80 beats per minute is reasonable in symptomatic patient. Class 2
Dancing and
recommend a more lean rate
dancing and
control, resting heart rate,
Kira?
10 beats per minute may be reasonable in patients who are asymptomatic and have preserved jet.
ये तुमने क्यों नहीं कलर से इतना किए?
Beta, okay. So ventricular rate control, how we'll do the control, how will we are controlling ventricles rate? Beta blockers, non-dihydropyridine calcium channel blocker like verapamil, diazam, because these calcium channel blocker are particularly working on the heart, not on the peripheral blood vessels. Digoxin, amiodarone, these are for drugs which are controlling the rate of ventricular rhythm control. The other thing, like if the heart is not contracting at proper spaces, like after the time, exact time, so then you can go for the rhythm control approach. In rhythm control approach, we are class 1C antiarrhythmics, 80%, 90% efficacy, which is in this basically flecainide and propofol use can be considered first-line therapies for patient without structural heart disease. If there is some structural heart disease, then this antiarrhythmics cannot work because you have to correct the structure first, then these things can work. Propofol also displays some non-selective beta blocking properties. That's why it will also work as a rate control. Class 3 antiarrhythmics, amiodarone, is usually used in practice. 85 to 95% efficacy, sotalol, 50 to 60% of efficacy in the dofetilide, dronedarone. These are used basically from class 3 antiarrhythmics to control the rhythm of the heart. How they are managing the atrial fibrillation? If there is no structural heart disease, then these are the options: dofetilide, dronedarone, flecainide, propofol, sotalol, and if it's not working, you can go to amiodarone. And if it is still not working, then you can go for catheter ablation, means that you will put the catheter and fix the problem. If it is non-structural heart disease, if it is structural heart disease, you will see what kind of structural heart disease is. If coronary heart disease or heart failure. If coronary heart disease, you will go for dofetilide, dronedarone, sotalol, and then amiodarone. You can go catheter ablation anytime. Heart failure, you will choose more amiodarone and dofetilide. And next, anticoagulation, how you will manage the anticoagulation. As we have discussed that in atrial fibrillation, the blood is not flowing at its rate, means blood get pulled somewhere in the heart, in the arteria, behind the walls, and it can coagulation. If it is more than 48 hours, it's for sure most of the time that the blood has coagulated. If it is a less than 48 hours, it's like they have chosen on the basis of the time. If it is more than 48 hours or less than 48 hours. If the more than 48 hours, they have to consider the patient that there is coagulation of the blood, and if it is less than 48 hours, they will consider that there are less chances of minimum chances of coagulation. So before starting therapy of cardiovarian, basically these guidelines are for cardiovarian. For doing cardiovarian, they cannot fix the heart, abnormal heart, just straight if the patient is coming with atrial fibrillation, and they will just fix it. Because the patient might have some clot, and after fixing this heart, the blood will start flowing properly, and the clot will go to the lungs or to the brain, and it can brain hemorrhage, or it can cause pulmonary embolism. So first of all, they will choose the anticoagulation, initiation of anticoagulation therapy before every cardiovarian. This is the recommendation class 2AB. You can give unfraction heparin, low molecular weight heparin, epic 7, loading dose, and then you can do cardiovarian. Initiate post-procedural AC therapy 4 weeks for all patients. You have to give. And long-term anticoagulations based on CHADWA score, you can choose whether this patient is candidate for long-term therapy or not. This score helps because in an anticoagulation chapter, you will go for this CHADWA score. If the patient is suffering from atrial fibrillation, and it has been more than 48 hours, you will first have to rule out that there is no clot. Then you will go for cardiovarian. First thing is this one: you will do tracheal echocardiogram. In this way, you will be you are putting some device from trachea, and you are observing in arteria and heart if there is any clot. The other option is this one, that you will just give first anticoagulant and anticoagulation for 3 weeks, then you will do the therapy. And you have to for this one pre-procedural, again you will have to, after confirming that there is no clot, if you have performed tracheal echocardiogram, so then you will choose any of anticoagulant, and you will do cardiovarian. Then you will again, this step is same for post-procedural 4 weeks anticoagulation. For long-term anticoagulation therapy will be based on this score. We will discuss now anticoagulation therapy. Basically, this score is categorization for the high-risk patient, from the low-risk patient, and from the non-risk patient that which can get a clot, which can get. So for risk classification and treatment determination is based on CHADS CHADS was score of not 2018 chest guidelines for anticoagulation in atrial fibrillation no longer recommended antiplatelet therapy alone for prevention of stroke or systemic embolism. This one, there are some 7 scores, 7 points. For everything they have given some score. You have to calculate those scores. If congestive heart failure, a left ventricular ejection fraction is less than 40%, there is 1 score. Hypertension, 1 score. If age is more than 75 years, 2 score. If age is 65 to 74 years, 1 score. Below 65, no score. Diabetes, 1 score. Stroke, transient ischemic attack, thromboembolism, 2 score. Vascular disease, 1 score. Sex category, if it is a female, 1 score. So this one, this is very important. Most of the time it comes in the exam. This CHADWA score, there is some question. That's why I have put some clinical case. BW, 70, 80 years old man with history of hypertension disease, gastroesophageal reflux disease, and asymptomatic atrial fibrillation. For past month, his therapy includes aspirin 3 to 5 milligrams, lansoprazole 30 milligram every night, atenolol 50 milligram per day, lisinopril 10 milligram per day, and atorvastatin 20 milligram. His vital signs include BP 132, 72 millimeter mercury, and heart rate 68 beats per minute, which is the best therapy for BW. If he has given you some points of a CHADWA score, you will have to always calculate them. 78 years, 2 point. If you will go back, 2 points for this one. Okay, peripheral artery disease, 1 point for this one. And 1 minute, this history of hypertension, 1 point for hypertension. Systemic atrial fibrillation. For atrial fibrillation, there is no score. And 2 points for age, hypertension, 1 point, and peripheral artery disease, 1 point, vascular disease. So 4 points for this patient. There are, so what will be the therapy according to this one? Add diltiazem and warfarin, add digoxin, increase lisinopril 20 milligram per day, discontinue atorvastatin and add warfarin and decrease aspirin 81 milligram. If the patient is doing very well, you will discontinue the therapy very carefully. This is the most, you can say that most critical question. If the patient is doing well, how you will discontinue the things. So, particularly to add diltiazem and warfarin, why you will add diltiazem? If the vital its heart rate is 68 beats per minute, so why you will add diltiazem? You will have to go for anticoagulation therapy, but not the diltiazem. It's doing very well. Add digoxin and increase the lisinopril 20 milligram per day. For this one, why you will do this one means if there is some problem, why you are adding digoxin and lisinopril, why you are adding it. They have not given anything like its BP is almost fine, and why you will add lisinopril 20, why you are increasing the dose. There is no reason. You can. There are two options. If you are very much sure about the question, you can go like first the treat what is the condition. And if you're not sure, you can rule out the things that there are two options to address any question. You have to rule out, because always there is a confusion. You will rule out the options one by one, which you cannot give. Then there will be whatever is left behind is most appropriate answer. So add warfarin and decrease the aspirin 81 milligram per day. So this is the most reasonable therapy, because you have to add warfarin, you have to give this for this patient, because this patient is already on 0.4 and there should be any anticoagulant, otherwise patient can bleed. Discontinue atorvastatin cannot be discontinued, because any person who is above 75 years, he should be on atorvastatin. So why you are reducing the dose of aspirin? Actually, aspirin is also anticoagulant and warfarin is also anticoagulant, but both performing on different levels. Like aspirin is antiplatelet and warfarin basically is doing with the factor and fibrinogen. So when the platelet coagulate, it is called primary hemostasis, and when the warfarin, when the factors perform and that pathway, it is a secondary hemostasis. So this one you will have to reduce the dose, and for both points you will give them the treatment, primary and secondary. Listen. Now the next our chapter is hypertension. Hypertension persistent non-physiological elevation of blood pressure. It is defined as having systolic blood pressure of 140 millimeter mercury or greater, having diabetes, having diastolic blood pressure of 90 millimeter or greater, taking antihypertensive medication, or having been told at least twice by physician or other healthcare profession that one has hypertension. Primary or essential hypertension is which have no identifiable cause, and most of the time, 90% of the time, the science is not capable enough to identify most of the time the cause of hypertension. Secondary hypertension, when there is some specific reason, Cushing syndrome, pheochromocytoma, primary aldosteronism, Benefits of treating elevated blood pressure: decreased risk of stroke, decreased risk of MI, decreased risk of heart failure. Actually, in our country, this is very sad reality that in hypertension, the symptoms are not like such that the our community take it very seriously. It's like a slow killer. It start damaging your health, it start damaging your body when it is out of the range. But our community, our people are like this until unless they will, something is not an illness. If you like are really feeling that one, or you are really restricted in your movements, or so blood pressure is hypertension is such a disease that needs more awareness in our society, where the people are very careless about their health. They only realize when some event has already happened, like stroke or MI or heart failure. Then and they realize that they have reached the hospital, then they will take it seriously. So this is the classification. It's more stricter than the older classification. Like now normal is less than 20 and less than 80 diastolic blood pressure. And sometimes the patient sometimes the patient has one of this one. It is called isolated systolic hypertension or isolated diastolic hypertension, if the patient is fulfilling one requirement but not the other. So normal less than systolic less than 120 and less than 80, elevated 120 to 129, less than 80. This is called elevated. Stage 1, 130, 139, 80 to 89. High blood pressure hypertension, stage 2, 140 or higher, or 90 or higher. Stage 1, usually they give one medication of hypertension, and stage 2, they treat with 2 medications of hypertension. It's just general practice. Hypertension crisis, this is an emergency situation, like when your BP is really high and anytime, any event can happen, like you can have a stroke, you can have like kidney damage or like retina damage, anything can happen anytime. So it's called hypertensive crisis. There are specific guidelines for treating hypertensive crisis. So this is the point, like whole, you will treat the hypertension. Basically hypertension, whenever you are treating the hypertension, you have to always consider the comorbidities, morbidities, that what other problems the patient is having. And sometimes they are very related with each other to cause the hypertension. Like if the patient has diabetes, you have to start with ACE inhibitors, ARBs, calcium channel blockers, or thiazide. ACE and ARBs are preferred in albuminuria. In diabetes, usually you're in the glomerulus, those filtration cells get glycosylated, means they, due to the extra glucose in the blood, so that your kidney is more damaging. When you will give ACE inhibitors, it will perform 2 functions. One, it will stop damaging your kidneys by dilating afferent arteries, and also generally blocking the RAS system. Chronic kidney disease also. Chronic kidney disease in also ACE and ARBs patient with albuminuria, same problem with diabetes. Basically, you're protecting your kidneys. Stroke and transient ischemic attack, thiazide, you will start ACE inhibitors, ARBs. Coronary artery disease, beta blockers, Z inhibitors. Beta blocker in coronary artery disease, your coronary artery is already blocked somewhere, and it's not supplying the blood proper to the heart. And by giving the beta blockers, it will also reduce the blood pressure, hypertension, and it will also the cardiac function. Heart failure, reduce ejection fraction, as we discussed, ACE, ARBs, beta blockers are first choice for this. Heart failure, preserve ejection fraction in this form when there is not enough blood going in the heart and not coming out of the heart. You have to give the diuretics to reduce the total volume of the blood in the heart. So this is clinical case 4. WD is 55 years old, white female who was recently admitted to the hospital with acute myocardial infarction, which was treated with the stent. She has past history of hypertension GERD. She is visiting your clinic today for management of her cardiovascular medication. Her vitals today include BP 158/86 or 152/86. 152 is problematic, and her heart rate is 82 beats per minute. Her labs are all renal, including sodium 140 millicolon, potassium 4.3 millicolon, serum creatinine 1 milligram. Her current medication regimen includes clopidogrel 75 milligram daily, aspirin 81 milligram, atorvastatin 40 milligram daily. What is the most appropriate approach to manage her hypertension? If you will see this patient is taking clopidogrel, aspirin, atorvastatin. There is no any hypertensive, antihypertensive medicine. Clopidogrel, they are all dealing with the platelets and with hyperlipidemia. So what's the blood pressure? 152/86 means this one will come in class 2 as per our classification. 152, 140 or higher is isolated systolic hypertension. So this patient should be treated by 2 drugs. Now, one option is removed. Add carvedilol, remove. Add lisinopril, monotherapy is removed. Now we have to choose with these 2 things. We have ruled out already A and B, B and C is there. Add lisinopril and metoprolol, add amlodipine and metoprolol. In American society, the race matters a lot because white, there in the community, basically, there are 2 major races when we are dealing with hypertension. White, native and black African people. So when they are mentioning this white female, it also means you have to consider these things also in your exam, because they are taking exam according to their population, according to their patients. And there is one only exam which is everywhere is same. And if we have to consider their society when we are treating someone. So mostly calcium channel blockers are not very effective in white females. So that's why the amlodipine, we will remove this option. If it will be the African, we will consider amlodipine. For this patient, we will go for lisinopril and metoprolol. This is because for this patient, we will choose 2 antihypertensive medicine. This dyslipidemia is our last topic to discuss. Dyslipidemia is an abnormal level of cholesterol and other lipids, also called fats in the blood. Goals of therapy: reduce CV morbidity and mortality, achieve LDL-C goals when appropriate. Non-pharmacological recommendation, pharmacological, there are some non-pharmacological, that diet control, that you should reduce the weight, you should exercise. These things are non-pharmacological recommended, changing the lifestyle, reducing the alcohol intake, like this. Pharmacological recommendation, therapy recommendation are divided into the patient management groups: secondary ASCVD prevention, atherosclerotic vascular disease risk they are calculating. This is some severe hypercholesterolemia, LDL greater than 190 milligram per deciliter, diabetes mellitus, primary prevention. These basically we are dividing patient in different groups to treat dyslipidemia, and we will choose the therapy according to these groups, on which group the patient is falling, and we will choose its anticoagulation therapy. Steps are same. First, we will initiate statin therapy. Second, ezetimibe we will add. Third, we will consider PCSK9 inhibitors. These are some proteins which are destroying PCSK9, basically some receptors on the liver which are utilizing the lipids from the blood. So these proteins are destroying those receptors who will just inhibit those proteins, and those receptors, those who are utilizing the lipids from the blood, they will increase. It's the latest one. Pooled cohort equation is a way to estimate 10 years ASCVD risk. It has some components, but in the end, it calculates some score according to which you will categorize a patient in different categories in different groups. It's an application in your phone you can download, and you can also calculate online from this score. But outcome of this score, like a low risk less than 5%, borderline 5 to 7.5%, intermediate risk 7.5 to 20, less than 20%, and high risk greater than 25%. These are our factors are considering when we are calculating this score. Therapy will always based on what's the score outcome from this ASCVD classification. So this is the categories of the patient, or the groups of the patient when we will manage, when we will give the treatment of these patients. Like in the first group, these are the groups, like if you are basing on ASCVD, the score will follow this path. And the second, if we are based on diabetes mellitus, if the patient are diabetes mellitus, we will follow this path. And if the primary prevention means there is no any event, you will follow this path, patient management group. In this class 1, this color is defining, this is specific color of the boxes. It's basically defining the treatment importance, like class 1 strong recommendation, this light gray color, this gray color. Class 2A moderate recommendation, therapy is reasonable, means it's right time to start the therapy, should be started, but you can calculate the risk benefit. But class 2B recommendation, therapy may be considered, like it's the choice of the physician. Sometime he should decide this, whether the therapy will be given or not. So this color pattern will basically tell us the importance of the therapy. First, ASCVD on the base of ASCVD. I'm explaining because this one sometimes it's hard to catch that what's the things are written over here. First, ASCVD, if very high risk, history of multiple major ASCVD events, or one or more event plus multiple high risk conditions, because there are many high risk conditions for this group. You will go for high intensity therapy straight. If not very high risk, then you will go for the age. Hyperlipidemia is always considered with the age, also linked with the age. When they are treating, they always consider the age. So not very high risk. If the age is less than 75%, you will are equal to 75%. High intensity statin therapy goal is to lower LDL-C less 50%, equal to 50%, whatever your is greater than or either greater than 50%. Whatever your LDL-C level is today, after the treatment, it should be below the 50%. If it's 100, it should be below 50 or 50. If the age group is greater than 75%, moderate to high intensity statin therapy, you can give. It's also because you cannot give high intensity therapy in 75 above age. You know, all of the statin group is called rhabdomyolysis, right? Muscles are losing. If the age is already very aged people are there, they already have very less muscle, so you also consider those factors. High intensity, and then second step, one is the statin therapy. Second step, consider ezetimibe after statin therapy if LDL-C is greater than 70 milligram per deciliter. After giving high intensity therapy, the outcome is LDL-C, then you reasonable to consider this therapy according to this color coding. And if for the second step, consider ezetimibe after statin therapy if LDL-C is equal to or greater than 70 milligram. Maybe consider, it's your choice of the doctor. He has to calculate risk benefit. Next step, consider PCSK9 after statin ezetimibe if LDL-C greater than 70 milligram per deciliter, non-HDL-C is greater than 100 milligram per deciliter. So next step, severe hypercholesterolemia. If there is a condition, if LDL-C is greater than 190 milligram per deciliter and age 20 to 75 years, you will go for maximum tolerated statin therapy, and you will go to the next step if you are not able to achieve the desired step, and you will again go to the next step according to this PCSK9. You will consider this one if you are not able to fulfill these conditions. Then diabetes mellitus, there are 3 age groups: 20 to 39, 40 to 75, greater than 75. You will choose 20 to 39 may be reasonable to initiate statin therapy if multiple risk factors or risk enhancer are there. And then age 40 to 70, moderate intensity statin, high intensity statin for patients with multiple ASCVD risk factors. 10 years ASCVD risk factor greater than 20%. Age is greater than 75, continue previously initiated statin therapy. Initial statin therapy benefits outweighs the risk if the patient age is 75. So primary prevention, age 40 to 75 years, LDL-C is 70 to 189 milligram per deciliter. You class 1 strong recommendation. If in this age LDL-C level is this one, so there is a recommendation that you have to consider. Sorry, this one is not related to this. Basically, this one is related to this one. This is just a category of the patient, how you will treat this patient. Calculate 10-year ASCVD risk using the pool cohort equation and determine if the risk estimate plus risk enhancer favors statin therapy. Low risk, less than 5%, borderline that we will calculate, we will choose the therapy accordingly. If less than 5%, lifestyle modification, reassess every 4 to 6 years. From this, there are always some questions most of the time that how you will go for the statin therapy for this patient who is falling somewhere, and sometimes they give the calculator. Most of the time they will give you the calculator raw risk, borderline risk, and what the step should be. It should be in your mind that how you will consider this one. Like this is the clinical case number 5. I'm a 63 years old white woman who has just finished 6 months of diet exercise for dyslipidemia. She has a history of hypertension, diabetes, mellitus, and asthma. She smokes 1 pack of cigarette. This is the risk factor. And drinks 3 beers per day. This is another risk factor. Her mother had hypertension, another risk factor, and suffered an MI at age 42 years. Her father has hypertension, diabetes, mellitus. Her medication are albuterol, metadose inhaler, lisinopril, metformin, linagliptin, calcium carbonate, antacid. Her vital signs include BP 134/84 millimeter, mercury heart rate 75 beats per minute. Her laboratory results are as follows: HDL-C 38, LDL-C 134 milligram, still high, triglycerides 186 milligram, TC, total cholesterol 209 milligram, and hemoglobin HbA1c 8.6. Her pooled cohort equation for risk factor is 27%. What's the most next step for MM? Medication are albuterol, lisinopril, metformin, linagliptin, calcium carbonate, acids. There is no any there is no any anti-hyperlipidemic going on in this patient. So first step is always, although when we'll see like this picture, we will say that initiate high intensity therapy plus ezetimibe when there is no done first step. For this one, we will initiate high intensity statin therapy, and after this evaluation, if we are not able to achieve any, like it's coming on this somewhere here. like high intensity statin therapy. For this one, first we will consider this, then we will go for the next class to add ezetimibe or something for this patient. And I have done with this presentation today. So any questions from the chat, I will just open. If you guys have any question, you can post over here or you can coordinate with Dr. Aisha. Thank you everyone for participation.